I'll briefly go over our faculty members, as I don't believe you've heard any of this. Dr. Kohlberg is our first presenter, and he'll be discussing interventional ultrasound as an overview. He's a faculty member here at ASMI and completed his residency at Emory in PM&R and his fellowship at sports medicine in ASMI. Dr. Kendall is a non-surgical sports medicine physician as well at Andrews in Gulf Breeze, and will be discussing ultrasound guided carpal tunnel release. He graduated from the Cooling College of Medicine at ETSU, completed a residency also in PM&R, and then a fellowship at Andrews Sports Medicine in Gulf Breeze as well. He's a team physician for the Pensacola Blue Wahoos. Next up will be Dr. Hunter Garrett, who will describe his technique for ultrasound-guided microinvasive trigger finger release. He completed family medicine residency and a subsequent fellowship here at ASMI. Dr. Garrett provides care currently at UT Chattanooga and covers Bryan College. Last but not least, one of the current primary care sports medicine fellows, Dr. Beetleman, will be talking to you about ultrasound-guided first compartment release for DeQuervain sinusitis. Matt graduated from the University of Alabama and is currently doing his fellowship here. He does coverage at Homewood High School, Sanford University, and the Birmingham Barons. After the presentation, we'll have some time for Q&A via the panel discussion. So with that introduction, everybody please welcome Dr. Kohlberg.
Thank you, Daniel. Thanks for the introduction. And I want to thank the American Sports Medicine Institute for organizing this webinar. I think it's a great topic. Basically, interventional musculoskeletal ultrasound is truly the future of orthopedics and sports medicine. And we wanted to concentrate our attention today on some of the advanced procedures that we're doing that are a little bit more experimental, and specifically looking at some of the procedures that we're doing for the hand and wrist. So let me share my screen. So I'm going to give an overview on the interventional musculoskeletal ultrasound procedures that we're currently doing in our clinic and some of our sister clinics down at Gulf Breeze and some of the other facilities around the nation. So first of all, some disclaimer, I do have a current grant from Smith & Nephew. And also, I'm going to be presenting procedures that are considered experimental, and they're not the standard of care. So I do want to clarify that. They are under research. There's a lot of promising findings, but they're still not considered standard of care for many of these. So today I'm going to briefly review the role of ultrasound, and then we're quickly going to dive into ultrasound guided procedures. I classify them as first generation, second and third generation procedures. So ultrasound has become very popular in sports medicine. The ultrasound imaging allows you to see structures up to 5 times larger than with MRIs. Now we have machines that you can see sub-millimeter structures, such as the valves of veins. It also serves as a quick and accurate extension of your physical examination. So basically, if someone is hurting in a specific spot, you can put the ultrasound machine right on top of there and see what's going on. In addition, ultrasound allows you to do something that no other imaging modality allows you to do in a fairly accessible manner, which is doing the dynamic examination of an injury, such as ulnar subluxation of the ulnar nerve or a joint instability or so forth. And then finally, what we're going to focus on today, I truly believe that ultrasound guided procedures is the future of microinvasive procedures. And I see this, we're currently right now sitting at where we were 50 years ago with the arthroscope. So there's a paradigm shift that it's slowly happening in our field. Same way as 50 years ago, no one would have imagined that we would be repairing the labrum under a scope or repairing a rotator cuff under a scope. And now that is the standard of care. So there's a lot of procedures that we currently believe we cannot do them. And it's just because we have not explored the way to do them. But I'm going to show you different studies that have been done on new procedures that are truly mind-blowing and mind-opening and eye-opening. And so it's actually fascinating what research is happening out there. So we're going to focus our attention on the ultrasound guided procedures. I classify them by generation, first, second, and third generation. That first generation is what most residents learn to do. It's the joint injections, tendon sheets, maybe some nerve blocks, aspirating cyst. Second generation procedures, they get a little bit more engaging. So that's doing the PRP injection, for example, doing a barbotage of a calcific tendonitis, doing a tenogram or a hydrodissection. And then we're doing a lot of research in third generation procedures, which are more advanced procedures. And some of the ones we're going to talk about today include A1 pulley release, bursectomies, ganglionectomies, carpal tunnel release, and compartment release. And so today we're going to focus on the second and third generations. We're going to skip the first generation since those are fairly straightforward. So first procedure, just to briefly mention, doing the tenogram can be very helpful for diagnostic purpose. So basically, this is a case of a patient that had an MRI that showed what was described as a partial rotator cuff tear. And we basically put a 25 gauge needle in there and injected a little bit of lidocaine. And just watching the fluid travel through the soft tissue will give you a lot of information. And we actually saw that this patient had a full thickness rotator cuff tear. And it was not just a partial thickness tear. So that does change the treatment plan in many cases. Barbotage is a procedure that has been known for some time, and doing under ultrasound is very helpful. So we specifically presented a case report in the Journal of PM&R and in the AMSSM meeting of a patient that had a tophaceous gout cyst in the patellar tendon. And so under ultrasound guidance, we were able to debride that cyst, clean it up, and afterwards we did inject PRP into the tendons because there was a defect. And so you can see the images 3 months later, that tendon healed very well. The patient, in fact, he was pretty much pain-free the day of the procedure, because as soon as you take the pressure off from that tophaceous cyst inside the tendon, he was great. He was pain-free and walked away very appreciative. Now, I'm diving now more into some more advanced procedures that we're going to be going over today. So superficial Achilles bursectomy was something that we tried with a case report. And basically, we used a coablation one for a college level athlete that had retro Achilles bursitis or superficial Achilles bursitis and some peritendinous inflammation and edema. And so we used this coablation one to debride that bursa and tendon. And so in this picture here, you see before and after the treatment, you see the retro Achilles bursa, or that superficial Achilles bursa, was very swollen. And after we debrided it, 8 weeks later, it was back to normal in size and echo texture. Another case report study that we presented in PM&R was doing a ultrasound guided ganglionectomy. So there was a lady that had a recurrent ganglion cyst in the plantar side of her foot, and she had a podiatrist remove it once and it came back. And so she did not want to do open surgery again because of the difficulty with wound care. And so we used this coablation technology to basically ablate that ganglion cyst. Basically, you're cauterizing it. And so we're able to get the cyst to go away. And 3 months later, she was doing great. We followed her up long-term and she did very well. Looking at tendon injuries, there's been a lot of marketing and a lot of research being done on tendon debridement. So there's various instruments that are out there. There's supersonic saline debridement and coablation debridement technology. They're all trying to achieve the same thing, trying to clean up a tendon that has pathology. They do it in different ways. The supersonic saline debridement is more of like saline irrigating that tendon with a high jet stream, and it helps break up some of the tissue. The coablation technology, using a radio frequency coablation one to cauterize that area and clean up the tendon and the inflammation. And so this is a case that we presented in a case report at AMSSM meeting. It was a 13-year-old highly competitive gymnast who had a chronic patellar tendon injury, and she had failed the PRP injection. And when we scanned her, we saw that the tendon on the left side had a lot of degenerative tissue. And so we opted for debriding that tendon with the coablation one. And you can see 10 weeks later, the tendon tissue was healing very well. The neovessels had gone away and the patient was pain-free and returned to sports. This is a very neat study, switching gears. And so again, I'm giving you a bird's eye view of a lot of advanced procedures. This is doing an A1 pulley release under ultrasound guidance using a filtration needle that you see in the middle. And so Hunter is going to talk more about this procedure, but on the top left corner, you see a video of the A1 pulley catching that tendon, and it's got a little nodule in the tendon. Top right corner, I'm putting some numbing medication in there and numbing up that area. And then afterwards, I use that needle to basically make an incision through that A1 pulley. And so the bottom right corner is after I made the full incision and that A1 pulley is out of the way. You can see that hypoechoic space where the ligament used to be, the A1 pulley used to be, and it's no longer there. And then the bottom left corner, you see the image of the tendon gliding smoothly through where the A1 pulley was and no longer catching. This has had great success rate, and Hunter's going to elaborate more on this. Now, we figured if we can release an A1 pulley, what about a DeQuervain tenosynovitis? Could we release that first dorsal compartment? So we went ahead and did a case report, proof of concept, and we were able to do it. And then now we have an actual case series that Matt Biddleman is going to be presenting our findings. He already presented at the MSM meeting. Following this same concept of being able to release structures under ultrasound, there's been a lot of research in doing carpal tunnel release under ultrasound guidance. And so now there's new technology with this ultra minimally invasive carpal tunnel release technique. And Brett's going to talk a little bit more about this procedure. Now, there are some other procedures that have been studied. A lot of them have been done at Mayo Clinic. They're doing a great job. Very fascinating, the studies that they've carried out over there. Dr. Jay Smith, Dr. Finoff have been leaders with this. And so they've looked at doing compartment release for multiple compartments. And here you see the anterior and lateral compartment release under ultrasound guidance. They've also tested posterior compartment release, cubital tunnel release, among other structures. They also tried looking at iliopsoas tendon release under ultrasound guidance. So for patients with snapping iliopsoas tendon, if we do a release surgically, it may cause morbidity. But if we do it under ultrasound guidance, there's a chance that the integrity of the surrounding soft tissue may be preserved. And therefore, you're able to release the snapping tendon, but still preserve the surrounding soft tissue integrity so it does not cause any instability of that joint or any chronic weakness. IT band release is also being explored, distal IT band, as well as adductor longus tendon, where they're basically releasing that tendon proximally for patients that may have athletic pubalgia or chronic groin injuries. And so I invite you guys to look up all these studies and read them because they're very fascinating. Some other things that have been explored: tarsal tunnel release under ultrasound guidance. Is the following very similar techniques than the ones we've seen with the other studies. Now, one last slide here. So very interesting what Dr. Alfredson has been doing. So he's actually now incorporating ultrasound imaging for his tendon debridements under arthroscope. So he believes that the arthroscope is great to see the tendon, but you can only see the outside of the tendon. You cannot see the inside. But if he uses the ultrasound, he now can see the inside of the tendon, see the whole tendon. And so he can make sure that he debrides what needs to be debrided, but doesn't sever that patellar tendon in this case. And so I found this very interesting study. So I always tell my fellows and residents and anyone that comes to any of our courses or lectures, this is giving you a bird's eye view of what can be done with ultrasound. If you're interested in performing these procedures, please don't just start doing them. I invite you to take advanced musculoskeletal ultrasound courses. Our patient safety is first and foremost. And so there's multiple courses that you can take. So thank you again for ASMI, and we will have an opportunity at the end for any questions.
Good evening, everyone. My name is Brett Kendall. I'm one of the non-surgical sports medicine physicians at Andrews in Gulf Breeze, Florida. And I too want to thank ASMI and Dr. Colbert for inviting me to be involved in this webinar. I think it's a great series of topics and needs to be out there. So I'm going to be talking about carpal tunnel release with ultrasound guidance today. I do have the disclosure that I am a Sonics Health consultant. So our objectives are going to be to go over the sort of what is carpal tunnel, what is the prevalence, what are the symptoms. We're going to go over the different treatment options, as well as really focus on carpal tunnel release, specifically with ultrasound guidance. So what is carpal tunnel syndrome? It's essentially a median mononeuropathy that occurs due to impingement of the median nerve at the wrist within what we refer to as the carpal tunnel. And the median nerve supplies motor to the thenar eminence at the base of the thumb, as well as sensory to the thumb, index, middle, and radial aspect of the ring finger, as we all know. This is the most common compressive neuropathy in the world. It affects 12 million Americans, 7% of all manual laborers. And there are well over 500,000, pushing 600,000 carpal tunnel releases performed every year for patients with severe or refractory symptoms. And the primary goal of the surgery, regardless of what technique is used, is really just to transect or cut the transverse carpal ligament that creates the roof of the carpal tunnel to release pressure on the median nerve and reduce pain, numbness, and tingling, which then improves the patient's function. Symptoms include, a lot of times patients will come in complaining of numbness, tingling, burning, pain in the median distribution of the hand. They will complain of nighttime symptoms where it wakes them up at night and they have to shake their hand out to get it to wake up. They'll have occasional shock-like sensations in the median distribution oftentimes, complain of weakness in the hand. And in severe cases, it can really mimic like cervical radiculopathy type symptoms because there can be radiation of symptoms up the arm toward the shoulder. Initial treatment usually starts with nighttime wrist splints to keep the wrist in a neutral position at night. Gabapentin, Lyrica, NSAIDs can be used to try to manage symptoms, occupational therapy, corticosteroid injections. But if all of that is refractory or the patient's symptoms are severe, basically carpal tunnel release is considered the only definitive treatment. There have been some studies looking at needle fenestration of the transverse carpal ligament under ultrasound guidance. And these have been shown to give relief of symptoms for several months post-procedure and have been suggested to be a potential alternative to surgical release. However, the gold standard certainly remains carpal tunnel release. Why do we use ultrasound guidance for carpal tunnel release? Well, if you really think about it, ultrasound guidance provides the largest field of view of any of the options available. If we think about ultrasound guided minimally invasive procedures, anytime you're talking about minimal invasiveness, you think that, that implies reduced exposure. And exposure is essential for procedures and surgeries. We have to see what we need to see, to do what we need to do, to protect the at-risk structures in the process. So one would assume that decreased exposure reduces visualization, which is usually the case. However, image guidance and ultrasound can compensate for this because we are able to directly visualize the structures through the skin. And this really serves as what I like to term as an exoscope. Carpal tunnel release with ultrasound guidance has been in the literature for years with over 30 publications dating back to 1997. Over 20 clinical trials have been done and published on with over 1,700 wrists and over 1,300 patients. In the published data, there are no reported neurovascular injuries. There are no intraoperative conversions reported to open procedures. Follow-up ranges from anywhere from 3 months to over 2 years, and it has an excellent clinical outcome of over 97% success. As Dr. Colbert mentioned, Dr. Rojo Manuel, he's a hand surgeon out of, he's from Spain, but he practices in Dubai. He did a study where he randomized patients into an ultrasound group and a mini open group, and he performed all of the surgeries. He followed the patients for about 12 months and reported no complications in the ultrasound group. And the ultrasound group showed 5 times faster return to activity, discontinuation of medications, and relief of paresthesias. There's also potential for cost savings because the procedure does not typically need general anesthesia. There have been various tools that have been developed over time to try to help improve the technique of carpal tunnel release when using ultrasound guidance. And in my practice, I've specifically implemented the XS1 MICROKNIFE made by Sonex Health. I started the cases, my first day of cases were in October 2018. This is a picture of me on the left, training with Jay Smith, who's there to my left, and went to Rochester to do that. And I implemented it in October of 18 and have done 617 wrists since that date. I performed all of these in the outpatient procedural area of the hospital. Almost all of them have been with local anesthesia. I usually offer Valium like an hour before the procedure if the patient wants it. A lot of patients don't take that. And if they don't take the Valium, I'll let them drive themselves home. The procedure times are somewhere between 3 to 7 minutes from incision to device removal. The wound size is under 5 millimeters. Typically after surgery, we just manage postoperative pain with compression, elevation, NSAIDs, and Tylenol. We don't really see any need for opioid management. Have not had any major complications. I've had 14 cases of pillar pain, all of which have resolved within 3 months. I had one diabetic that had an A1C of like 12 that had a delayed wound healing issue, which lasted about 3 weeks, but ended up doing fine. And we've really had excellent outcomes. And this is pending publication currently. When a patient comes in wanting carpal tunnel release, typically we want to make sure on an EMG, that's the way I practice, because that's considered gold standard, although we can diagnose it with ultrasound as well. But I certainly will always do a preoperative diagnostic ultrasound to ensure that they have adequate safe zones and no anomalous anatomy that would preclude doing the procedure safely. Here's a picture of the carpal tunnel inlet. Left of the screen is radial. You see the scaphoid and the pisiform bridging the inlet of the carpal tunnel on the extremes with the flexor carpi radialis superficial to the scaphoid. You have your median nerve and flexor tendons within the carpal tunnel and your Guion canal with the ulnar nerve and ulnar artery just adjacent to the pisiform. You can see here the transverse carpal ligament draping across the carpal tunnel, and that is our target for the surgery. When we scan just distal to the outlet of the carpal tunnel, we will find the recurrent thenar motor branch, which is a branch that supplies motor innervation to the thenar musculature. And this is an essential branch to identify because we certainly do not want to damage that during the procedure because that is the sole supplier of that thenar mass. So you can see it here looping around the ulnar aspect of the thenar eminence to go to swing around and supply the musculature. And if you look on a cadaveric dissection, you can see that this looks very similar to the way it looks when we dissect this out. You have that recurrent thenar branch that loops around the thenar eminence there. Moving on down to back to the inlet, I guess I should say, you see the hamate and the trapezium are the borders of the outlet of the carpal tunnel. And you have the transverse carpal ligament bridging across with the contents deep. The ulnar nerve and has branched at this point, so the superficial and deep branches are seen there with the ulnar artery as well. The transverse safe zone is defined as the ulnar aspect of the median nerve over to the radial aspect of the ulnar artery. And this is the zone in which we want to guide the device because this is where we're going to transect the ligament without damaging any sensitive structures safely. When we rotate in long axis or in the sagittal plane on MRI, we see that left of the screen is distal. You have the transverse carpal ligament, the palmar fat, the mid-palmar fat is there just past the distal taper of the transverse carpal ligament, and that's actually the target that they look for with the endoscopic approach to know that they've gone past the distal taper of the transverse carpal ligament so that they can ensure they get a complete release. And we look for that on ultrasound as well. And then the superficial palmar arch is down distal from there. The longitudinal safe zone is also defined as the distal taper of the TCL down to the superficial palmar arch. And this is the zone in which we will activate the knife during the procedure. And we don't want to be too distal because you get into the artery. You don't want to be too proximal because you won't capture the distal portion of the transverse carpal ligament. When we start the procedure, we make a small incision in the distal forearm at the level of the proximal wrist crease. This is about 4 to 5 millimeter in stab incision using a 15 blade scalpel. And we will guide the device down through the transverse safe zone region and make sure that we get the knife just distal to the distal taper of the TCL. And you can see that shark fin appearance in the bottom right-hand corner, just under the purple arrow. That's the knife. And we want to make sure we get that down just distal to that taper to make sure we get a complete release. Once we have the device in good position, we confirmed positioning, confirmed the recurrent thenar branch, the palmar cutaneous branch, the third common digital branch, make sure that we're safe from all of that stuff, as well as the superficial palmar arch. We activate the balloons. The balloons fill with sterile saline, which really just increases the safety of the procedure by displacing the median nerve radially away from the transverse safe zone, and it really increases the size of the transverse safe zone, and again, for increased safety. Once the balloons are activated, the knife can be deployed and is engaged within the distal taper of the transverse carpal ligament, and then that is distal to proximal towards you, transecting the transverse carpal ligament. I typically take 2 passes in all patients to make complete sure that I'm through the ligament. Occasionally, I'll take 3 passes if it's a really large individual. Sometimes only 1 is plenty fine enough. You just want to make sure you get complete through the full thickness of the transverse carpal ligament before you stop the procedure. And the way to confirm that is to then deflate the balloons and use the device as a method of confirming a complete release by supplying a volar force and videoing over the outlet at the level of the hamate. At the level of the hamate, you want to see the device come volar to the hamate level. And you can see here the transverse carpal ligament is obviously completely transected in both of these videos, and that confirms a complete release before the procedure is deemed complete. We pull out the device at that point, and you're left with this 4 to 5 millimeter incision that we simply place steri strips over. This is a patient on the left immediately post the procedure, and then the ones on the right are all 1 day post-op. We place steri strips, a folded gauze with some tegaderm, and then wrap that in Coban. I typically will follow up 3 to 7 days post-op for wound check, and usually by that time we can just put steri strips on the wound and let them start to shower. So in ultrasound guided carpal tunnel release ultrasound guidance is really the optimal method. I really believe that. It's been shown to be safe, effective, and lead to faster recoveries. The field of ultrasound guided minimally invasive procedures and surgeries is going to continue to expand. I like it. I sort of compare it to curling. The rock is coming down the way. We can influence the direction of the rock, but it's going to come, no different than it did in interventional cardiology. And old procedures will develop new methods. New procedures will be developed there as a result. And we got to keep in mind that this is all about patient outcomes and being patient-centric throughout the process. And as Dr. Colbert mentioned, we don't want to jump into doing these procedures and putting patients at risk. We really need to make sure we have the adequate training at the courses and things before we implement it on live patients. But collaboration is critical with our physician colleagues, both surgical and non-surgical, our ATCs, our therapists, etc. Our patients deserve it. Thank you, guys.
All right. So like I said before, I'm Hunter Garrett. I did my training at Andrews Sports Medicine, and presenting a topic that recently was published in one of our PM&R journals on a prospective study to minimally invasive ultrasound guided trigger finger release. Dr. Kohlberg and I worked on this in the years 2018, 2019, and during my fellowship year of 2019 to 2020. I have no disclosures currently. Our objective for this is to evaluate functional outcomes, determine resolution of symptoms via well-described pain scores with FAST scores and inertial scores, as well as quick dash scores, as well as to show statistically and clinically significant improvement after the procedure. So a little bit of background based on the A1 pulley and trigger finger findings. Typically, you find an inhibition of the smooth tendon to glide and a mechanical type impingement at the A1 pulley that ultimately causes a progressive pain, clicking, catching, and locking of the digit. It's somewhat described as stenosing tenosynovitis at the A1 pulley. Treatment options in the past have been splinting, anti-inflammatory steroid injections, and ultimately a trigger finger release. This occurs in about 2 to 3% of the population, but we see an increase in the diabetic population of approximately 10%. This occurs via fibrocartilaginous metaplasia of the tendon at the pulley, causing an increased type 3 collagen, ultimately leading to a pathologic nodule at the flexor digitorum profundus. Other associated conditions are rheumatoid arthritis, calcific tendonitis, diabetes, hypothyroidism, amyloidosis, sarcoidosis, and as well as carpal tunnel, which Dr. Kendall just alluded to, which is approximately 60% associated with this. Presentation, you'll see our grading scale on the right here. We're going to focus mainly on grade 2 and 3 classification during this talk. So again, this is pain with clicking and catching us and locking at the A1 pulley. And you may or may not have referred pain from the dorsal MCP and PI as well. And then they're going to have a triggering with the digit from flexion to extension. Standard treatments, as including first-line treatments previously, like we just talked about, are splinting, activity modification, anti-inflammatories. And about 40 to 90% of cases in literature supports these as a first-line treatment. In most practices, corticosteroid injections are used in a 1 to 3 type time frame, and it's best initially the best initial treatment for trigger fingers, and you'll still get a pretty good relief from this. Although corticosteroid injections are less likely to give you a full relief in diabetics. Again, it's also important to get a good history and make sure that the duration of the symptoms fits with your overall treatment course. Some complications for steroid injections can be tendon rupture, fat atrophy, as well as transient hyperglycemia. You can see the operative types with a success rate that is very high ultimately. So this study was a prospective case study with a population between ages 19 and 85 years old. The inclusion criteria included primary diagnosis of trigger finger with the following as you see there. Inclusion criteria also included grade 2 to 4, but we really focus on grade 2 to 3 trigger fingers. Exclusion criteria, widespread hand pain or complex regional pain syndrome, previous trigger finger release, any evidence of sclerosing tenosynovitis, inability to answer the questionnaires as we find difficult with all research, as well as previous steroid injections into the A1 pulley. So data collection started with initial visits with Dr. Kohlberg, who's our primary author, with a quick dash VAS score, as well as a inertial phase scale score. The follow-up was done at 2 weeks with repeat questionnaires done at 2, 6, 12, and there you see, and 6 months. The duration again was for 3 years with a primary score of quick dash score. Methods, so we used what was been previously described when doing ultrasound guided trigger finger release. You had approximately 90 to 95%, but it was a range of different tools. So this study was actually the first one to actually use the needle that you see here, which is one of the no-core needles that has an 18 gauge needle with an 18 blade at the end. And this is the first study of my knowledge to really use this. In addition to the new instrument, we also used 3 tests to confirm release during the study. And if any tests were positive, then incision was extended proximally or distally based on the level of the catch. Ultrasound guided diagnostic tendon sheath injection after release to visualize and ensure that the fluid is freely flowing down the tendon sheath. A dynamic ultrasound in which the tendon is observed gliding smoothly without mechanical catching, as well as a dynamic manual test. As you can see in the top left, this is the hand as you would be looking at it when you're doing your procedure. So you see the bone toward the bottom and the extensor expansion at the bottom of the screen as well. But again, that's would be more on the dorsal portion of the hand. as you're looking at it on the ultrasound with the comparison image directly on the right, you can see the FDP tendon present. You can also see the A1 pulley that's been highlighted with the red circle. You can see the A1 pulley again in cross and longitudinal axis in number 2B, and then you can see the A1 pulley with mild increases as far as the size of it at the level 2C. This is the ultrasound machine that we used. We also always check neurovascular structures prior to doing any type of procedure. This is an evidence of mechanical catching that you may have seen from previous. Again, you can see the A1 pulley that's catching. This is, again, a right middle finger. So we'll look at that again. Here's the catch right there. So the procedure itself was done in a distal to proximal fashion with 3 milliliters of lidocaine with epi injected into the soft tissue with a 25 gauge inch-and-a-half needle. And this was, again, done under ultrasound guidance with Doppler. This was done to really separate the adipose tissue from the A1 pulley, but also seen where it goes down the tendon sheath to make sure you're doing it the proper way. And you can see this procedure being done. You can see it flowing down the tendon sheath. Again, I'll play that again. The puncture incision is done in the skin with the 18 blade, and then under ultrasound guidance, carefully advanced in the plane down to the A1 pulley and flexor tendon. Once the incision was made through the A1 pulley, it was done in a distal to proximal fashion. Here you can see the needle being slowly done, going from distal to proximal, as we're slowly getting to that A1 pulley that we identified earlier in this area. I'll show that one more time. With confirmation of release, this was done via anechoic incision through the A1 pulley with grayscale and ultrasound images in 2 planes of view. So again, in 4A, you can certainly see that A1 pulley being present. In 4B, you see a release of that. In 4C, again, you see this is the horizontal axis where you're seeing it in the seeing it with a red circle, and then 4D, you see that released A1 pulley. Again, we always want to make sure we're identifying the neurovascular structures that you see there as well. The first test is where we take the 20 gauge inch-and-a-half needle that's in longitudinal view down the tendon sheath and inject 1 to 2 milliliters of normal saline. You really want to make sure that you see the free-flowing area going where the A1 pulley was released. So you want to see it going down the flexor tendon. You can see that where the adipose tissue is pulled off and the fluid goes down. I'll show that again. The second test was an evaluation under ultrasound to make sure the tendon is gliding smoothly. I think this is one of the best things about ultrasound ultimately, which you can see once we show this video, is it'd be difficult to see this in an open case due to the view that you would ultimately have. So now we saw the catch earlier, now you see that there's no catch there. We'll show that again. The third test is where the patient actively flexes and extends the hand during the test to make sure that they're not feeling any subsequent catching either. Post-procedure protocol, bandage was done for the first 24 hours, then a nice splint was used for 7 days. They were really able to resume all activities of daily living within 24 hours. Medications typically were ice, Tylenol, or ibuprofen. Results with 79 procedures with an average age of 62, with an average trigger finger grade of 3, and a final follow-up at 18 months. We have significant decrease in quick dash, inertial, and VAS scores, as you can see by this graph. There's no complications documented at the time of procedure or any of the subsequent visits or surveys. This was done under sterile and direct visualization via ultrasound, would significantly decrease any other complications as well. Some of the limitations for this study ultimately were some interviewer administered versus self-administered bias. Each procedure was not necessarily a different patient, as we had 16 patients that accounted for 33 of the 79 total fingers. And then this is an operator dependent procedure, like Dr. Kohlberg initially mentioned, that this really is a stage 3 ultrasound guided procedure, and being able to really use ultrasound as a tool for most of our primary care non-surgical affiliates. So in conclusion, this micro-invasive technique using an 18 blade was really the first of its kind. We also used the 3 confirmatory test to confirm full resolution of mechanical symptoms. 97.5% of patients, which is pretty close to what open procedures will have, showed complete resolution. 98.7% required further treatment, with a long-term follow-up average of approximately 18 months. Again, this is recently accepted in the PM&R journal, the Journal of Injury Function and Rehabilitation. There's some references for the study. And again, thank you for allowing me to be a part of ASMI and such great things going on. I will pass it over to one of our current fellows, Dr. Matt Beidelman.
Hi, everyone. My name is Matt Beidelman. I'm one of the current fellows at Andrews Sports Medicine and ASMI. I'm going to pull up my PowerPoint here. Just one second. Can everyone see that? All right. Everyone good? Everyone can see that?
Yes, sir.
Yeah, so like I said, I'm one of the current fellows here at Andrews. I want to thank Dr. Kohlberg and ASMI for allowing me to present this study, which is very similar to what Hunter just spoke about with the trigger finger. We can do a very similar procedure at the first dorsal compartment for DeQuervain's tenosynovitis, and this is a newer procedure and one that we're doing a retrospective case series to look at outcomes on this procedure, and I'll discuss that now. I have no disclosures. So for some background, DeQuervain's tenosynovitis is inflammation at the first dorsal compartment and involving the abductor pollicis longus as well as the extensor pollicis brevis tendons. Initial conservative therapy, including activity modification, splinting, OT, PT, as well as medications, is obviously the first thing to do. Also corticosteroid injections using landmark guidance or ultrasound guidance is usually the next step. After that, it gets a little bit murkier. There's been some papers citing PRP use, percutaneous needle tenotomy, as well as partial percutaneous release with an 18 gauge needle. In the literature, traditional approach has been after multiple failed either steroid injections or other procedures that would typically proceed with open surgical release. So the procedural criteria that we have used would be tenderness palpation over the first dorsal compartment, a positive Finkelstein's test on exam, failure of those initial conservative management interventions, and then finally a confirmed diagnosis of DeQuervain's tenosynovitis with diagnostic ultrasound imaging prior to the procedure. So looking at the anatomy of the first dorsal compartment, you're at the level of the radial styloid and have your extensor pollicis brevis tendon as well as your abductor pollicis longus. In the yellow circle there, you have your superficial radial nerve, which is one of the important structures that you will have to visualize and continue to watch for during the procedure. In the red asterisk is where you have the tissue of the first dorsal compartment, which you're trying to release with this procedure. So we use the same machine for our procedures. that Hunter did for the trigger finger. We are directly visualizing and live scanning for the superficial radial nerve and its branches near the first dorsal compartment prior, as well as any vascular structures. However, the radial nerve or the radial artery is more medial to the radial styloid, so usually doesn't come into play, but that superficial radial nerve can. So we're live scanning the entire time. We do initial diagnostic ultrasound to locate it. We visualize the first dorsal compartment in both short and long axis and confirm the diagnosis by visualizing the thickening of the extensor retinaculum. Then we perform a superficial radial nerve block, as well as local anesthesia at the level of the first dorsal compartment prior to performing the release. We use the same no-core needle that Hunter discussed for trigger finger release. Prior to the procedure and inserting the needle, we get a longitudinal view of the tendons within the first dorsal compartment, and then use the no-core needle to make an incision through the extensor retinaculum, followed by a similar irrigation technique as with the trigger finger. The release is completed with live ultrasound imaging with the needle tip in view at all times to ensure that no neurovascular structures are injured. So this is a view of the procedure. I don't have any fancy videos like Hunter did, hopefully will here soon. But you have your red asterisk showing a longitudinal view of the extensor retinaculum over your tendons within the first dorsal compartment. Your superficial radial nerve is there proximally, and you insert distally with the no-core needle and move proximally through that extensor retinaculum. So our case series that we did looking at this procedure was a retrospective clinical case series. Wanted to look at overall outcomes for these patients and then use some validated outcome measures, notably the VAS and inertial phase scale, to try to quantify the improvement of both their mechanical symptoms and pain. So given the retrospective nature of the study, we looked at the last 18 months of clinic visits using ICD-10 and CPT codes to find patients that had undergone this procedure. All had been done by Dr. Kohlberg. We then used inclusion and exclusion criteria, which none were excluded, and we ended up with 10 wrists. We then used the EMR to determine their pre-procedural VAS and inertial phase scales, which were obtained in clinic using the REMR, and then looked at their 2-week post-procedural visit to determine their subjective level of improvement. We then called these patients to determine their long-term follow-up for both the VAS and inertial phase scales, all of which were at least 6 months post-procedure. So we had 9 adults, 10 wrists, 1 patient that had the procedure performed bilaterally, 6 months apart from each other. The mean age was about 44. It was 5 men, 5 women. The VAS pre-procedurally was 4.1 mean, and the inertial phase was 2.5. All patients had mechanical symptoms, had failed conservative care, and had obtained the ultrasound guided release. Our results were that no patients required surgical consultation or open release subsequent to the ultrasound guided release. No patients had either vascular nerve injuries during the procedure. Their mean subjective improvement at their 2 weeks post-procedure was 75%. And at 100, we had got 100% long-term follow-up with a mean time of about 2 years. And all those patients' VAS scores were 0. And the mean inertial phase scale was 0.2. No patients ever reported any symptoms of neuropathic pain or nerve damage at any point during the average 2-year follow-up period. And both of these are plotted here, and the VAS score obviously is a quite significant decrease. So in conclusion, first case series describing this technique, we had no complications. No patients went on to require any further surgical releases or surgeries, and the outcomes for pain and symptom relief were significantly positive. So this does show that there is a minimally invasive technique that is an option to open surgical release for DeQuervain tenosynovitis. Some things to potentially look at moving forward to try to do a prospective evaluation, looking at this procedure versus both, kind of further longer term conservative management to try to look at the kind of natural history of DeQuervain versus, as well as comparing it to traditional surgical management with open release. These are my references, and that is all that I have. So I will send it back to, I think, Dr. Smith to start questions and answers.
All right, thanks, Dr. Bottleman. So a couple of questions for the panelists, but before, let me just run over briefly the housekeeping rules, as I did not have my mic on initially. So for those watching on Facebook Live, please send an email to ASMI's education coordinator, Caroline May, at carolinem@asmi.org with your name and credentials to receive your CEU certificate. They'll be mailed in approximately 2 weeks' time. Participants other than physicians and ATCs will receive a certificate of participation and attendance so that you can present that to professions board to receive credit for tonight's session. First question I get is for Dr. Kendall. And Dr. Kendall, the question is there a current use case for needle fenestration of the transverse carpal ligament that you would see over the release itself?
The studies that have been looking at the fenestration technique really, show improvement through 3 months, et cetera. Usually it's not really long-term data. They oftentimes are putting steroid in there at the time of the fenestration in the studies. And so, we expect there's short-term benefit with steroid injections into the carpal tunnel with regard to symptoms. I really feel that, once you have exhausted the basic, nighttime wrist splints, oral medication options, plus or minus some therapy, and or an injection, I think that it gets to the point where it's probably in the patient's best interest to do the release to avoid, permanent nerve damage. Once they get into the severe category on EMG, it's important to know that a lot of times they have some permanent residual. So if you can try to protect them from getting to that point, it's in their best interest long term.
And to follow up, Dr. Kendall, is there a case in which you would recommend an open carpal tunnel release as opposed to an ultrasound guided release?
Yeah, I mean, a few things to watch for before you commit to doing the procedure. Number one, you want to make sure that the EMG confirms it and or you have good sonographic evidence of it. You want to make sure they don't have any anomalous anatomy. You see persistent median arteries with these bifid nerves, sometimes that will course on the ulnar aspect of the two trunks. And so then you have an artery and an artery on the periphery of the safe zones. And so you got to be careful about some of those things. But if they have A1Cs above 8 or so, I learned my lesson with that one patient. It's one of those things that I've sort of gone to setting a limit there. The thing though that you see sometimes is if they have really bad flexor tenosynovitis type of symptoms, like a rheumatologic condition underlying, and on ultrasound they have a lot of Doppler flow. Those oftentimes I will send on just because that probably needs to be cleaned up. That's rare, but occasionally you'll see it. Otherwise, if you can't see very well, if it's a mechanic that has a real thick palm of the hand, black, and from all the, a little dirty appearing from where they work in the, on cars and stuff all day or whatever it may be, or farmer, sometimes their palm is so thick, it's difficult to see. And if you can't confidently see it in the clinic, you don't even taking it to the operating room. So those are also sometimes ones that I would suggest just sending them on.
Thank you for that. Next question for Dr. Kohlberg. In general, are there ultrasound guided procedures that would be limited by the defect or pathology size? In other words, is there a physical limitation to what you could potentially go after under ultrasound that you'd recommend something arthroscopic or even open?
There's definitely limitations to ultrasound. You know, one of the areas, for example, that that can be difficult to treat with ultrasound is the hip girdle, because if you have someone who is, you know, has a lot of adipose tissue in that area, or there, you know, there's obesity or whatnot, but in the end, adipose tissue absorbs a lot of the ultrasound image. And so it follows what Dr. Kendall was saying, you know, there's going to be limitations, actual physical limitations from body habitus that may not allow you to see specific structures. There may be adjacent structures that limit you from seeing, you know, pathology. So for example, if you have a rotator cuff injury and there's a significantly enlarged acromion, and the patient is also obese, and maybe harder to see that rotator cuff well and try to get it out from under the acromion to see it from under the bone. And then there's also, you know, component of size that, you know, if you have a big multiloculated cyst, for example, I wouldn't try to do a coablation of that. You know, if it's a small thing, you may be able to do it like we did in our case report. But if you have a big multiloculated cyst, you have to use common sense. And, you know, I mean, you also have to measure the risks that you're taking. You know, one of my mentors told me once, you know, don't ever do a procedure that if something goes wrong, you can't fix yourself, and, you know, and pull back. And so, you know, you have to take those measured steps and weigh the risk and benefits, because in the end, it's the patient's outcome that may be potentially affected. So that's why, you know, the fellows, I always tell them, listen, I need you guys to, and all of y'all have been through it, so I need you guys to be proficient with joint injections, with tendon injections before you can do an A1 pulley release. I mean, I'm never going to have a fellow do an A1 pulley release the first semester or the first month of training, or even the first 2 or 3 months, because I need to make sure that they're proficient, that they got the first generation procedures down, because it's such a highly operator dependent procedure, all these ultrasound guided procedures, that I cannot compromise patient safety for that. But it comes, you know, you're patient, and you keep striving, and eventually you will learn, and you will progress, and then you'll get to doing some more advanced procedures like y'all have done a great job with.
Thank you, Dr. Kohlberg. The next questions for Drs. Garrett and Kohlberg. Is there a reason for why the one patient in the triggered finger release study had incomplete release or relief?
So that one patient that did not do well, she actually developed a second trigger finger on the tendon next to it. And the first one that we had released, she did not have any mechanical symptoms, but she was having some soreness afterwards in that area. And so she opted for doing an open release. She was a little skeptical at first of doing the ultrasound guided procedure. So just going into the first time we did it, you know, she was a little skeptical. And I think that also was a bias on her outcome. But in the end, you know, she developed a second one, and she wanted to do an open release. And so she convinced the hand surgeon to do a revision of that first one. And granted, you know, basically the surgeon, you know, debrided the area, but it was, you know, it was not a second release per se. But mainly the reason that she got it was that she has some persistent soreness and pain in that area.
Great, thank you.
You know, I always say in medicine, nothing is perfect. And I always tell that to my patients, by the way. And I let them know ahead of time, you know, if you'll define expectations, and I think they'll save you a lot of trouble. So I always tell patients, listen, there's always that 1 in 100 case, or 2 out of 100 cases that there may be some issues, but, you know, nothing in medicine is perfect. Not even the knee replacement, you know, 20% of knee replacements will have complications. And so, you know, but you're upfront and you let the patient know.
Absolutely. Expectations are paramount. Dr. Beidelman, what was the convalescence time of your patients versus the open DeQuervain tenosynovectomy?
So like convalescent being like recovery.
Yes.
The recovery time, from my understanding, was very quick. I mean, they had 75% on mean recovery at 2 weeks of symptom improvement. So I think there was one patient that had a little bit slower recovery, in the fact that she at 2 weeks had about 33% subjective improvement, but everyone else was 75% or around there, or some were completely symptom free. So I would say, given the fact that there's no incision to allow to heal, it's significantly quicker.
And did you say that the release was performed from distally to proximally?
Correct.
And that's, I'm assuming, due to anatomical considerations?
Well, from my understanding and based on my visualizations, it allows you to visualize and spare the superficial radial nerve.
Yeah, there's two main reasons for distal to proximal. One, so if you have the patient drop their wrist, it's easier to advance that needle distal to proximal. Some people will have larger forearms, and so it'll be difficult proximal to distal. But then the second one is that superficial radial nerve. It will have a branch that frequently comes just proximal to that A1 pulley. So you want to stay away from that area. And by the way, you don't want to be over the snuff box either. So you do want to make that puncture just at the distal aspect of that retinaculum, of the retinaculum, just the distal aspect. So you minimize chance of injuring any other small. So the superficial radial nerve can have 2 to 3 little branches that will come out through that area. And so you want to try to spare them. But in our case series, we did not have any patients complaining of paresthesia afterwards.
Splendid. Well, thank you very much. That concludes the questions in the presentation for this evening. Again, there will be a survey monkey sent at the end of the presentation out to everyone to make sure that we've met your educational needs. Thank you so much for joining us this evening, and we look forward to seeing you next time. Thank you.
Thank you.